So, how do doctors actually diagnose ailments of the mind? I mean, think about it. There are no blood tests to draw, no x-rays to scan, and definitely no biopsies to examine. Well, welcome to The Explainer. Today, we are uncovering exactly how psychiatrists act as real-life medical detectives. Because instead of using a scalpel or a stethoscope, they have to rely on carefully structured conversation and just incredibly meticulous observation to decode the absolute complexities of the human mind. It is a fascinating, highly systematic process, and we're going to break down exactly how the whole shebang works.
Here's our roadmap for the analysis today. First, we'll look at the art of the interview. Then we'll move into uncovering the patient's history, transition right into the mental status exam, and finally, we'll wrap up by decoding thoughts and cognition.
All right, let's dive into Section 1, the art of the interview, and building that critical foundation of trust. Before any kind of medical assessment actually begins, the examiner has to bring out their most vital tools: empathy, privacy, confidentiality, and maintaining a strictly non-judgmental stance to help the patient feel safe enough to open up.
Right off the bat, a psychiatrist faces a pretty major tactical choice, toggling between open-ended and closed-ended questions. You see, they have to decide in real time exactly when to let the patient just speak freely so they can map out their internal world, and when they need to abruptly pivot to closed-ended questions to nail down specific, verifiable facts. It's really this delicate, kind of brilliant dance of communication.
But you know, it's not just about the words being spoken. The psychiatrist also has to navigate these totally invisible psychological tripwires. Take transference, for example. That's when a patient unconsciously projects feelings from their own past onto the doctor. And then, on the flip side, there's countertransference, which is the doctor's own emotional reaction bouncing back to the patient. A truly skilled examiner has to recognize these hidden currents if they want to stay perfectly objective. Moving right along to Section 2, uncovering the patient's history, or basically the backstory. Here, the doctor is hunting for the chronological narrative of the illness, pinpointing the exact onset of symptoms, specific life stressors, and things that might bring relief.
Now, the person sitting in the chair is obviously the primary informant, but, and this is a big but, because mental illness can seriously distort someone's memory and perception, this history often needs a reality check. So doctors rely heavily on corroborative history from a trusted family member or friend just to ensure the timeline and the facts actually line up with reality.
In this historical investigation, it traces a massive timeline. I mean, they go all the way back to antenatal care, they track early developmental milestones like weaning, toilet training, childhood night terrors, then they sweep through puberty, early schooling, and right into occupational, legal, and even military history. Every single phase of life is a crucial piece of this giant diagnostic puzzle.
Alongside that massive timeline, they also have to assess what's called the pre-morbid personality. Imagine trying to summarize your entire baseline personality in just a few words. That's exactly the goal here. Were they naturally optimistic, maybe more introverted? What was their normal sleep and appetite like? You absolutely have to know the baseline so you can measure exactly how far the illness has shifted the patient away from their true self.
Okay, let's get into Section 3, the mental status exam. Observing the present state. If the history was all about listening to the past, the MSE sharply shifts the narrative to a real-time, intense snapshot of the present moment.
Think of the doctor here as a medical detective, rapidly firing through a visual checklist. They're looking at physique, posture, even the patient's gait as they walk into the room. Is their eye contact piercing, evasive? Maybe it's totally absent. They're on the lookout for abnormal motor movements or any subtle signs of hallucinations. In this room, literally every single flinch and gesture is data.
Now, there is a classic point of confusion in psychiatry that we definitely need to clear up: the difference between mood and affect. Mood is subjective. It's what the patient tells you they feel, like, I feel incredibly sad. Affect, however, is the objective, external expression that the doctor actually observes. The examiner is checking, does the affect actually match the mood, or is it rapidly swinging back and forth, which is a condition clinically known as lability.
The examiner also tracks speech, kind of like how a musician tracks tempo, carefully noting fluency, rate, tone, and volume, because rapid-fire, pressured speech gives you completely different diagnostic clues than long-delayed pauses. They also probe for perceptual distortions, things like hallucinations, illusions, or feelings of depersonalization. They are trying to capture exactly how this patient is actively experiencing reality right now.
Finally, that brings us to Section 4, decoding thoughts and cognition, peering inside the mind. Now we're moving from how the patient perceives the outside world to how they process it internally. turning abstract thought into structured data.
First things first, they have to identify the actual content of the patient's thoughts. Like, what is the exact theme playing on a loop in their mind? The examiner is hunting for fixed, false belief, delusions. They are looking out for highly irrational phobias or overwhelming obsessions. This tells the doctor exactly what the patient is thinking about.
But equally important to what the patient is thinking is how they are thinking. This is known as thought form, the logical architecture and flow of a patient's ideas. And honestly, this is where we encounter a really fascinating array of clinical jargon.
Recognizing disorganized thought is just absolutely critical. For instance, a patient might be circumstantial, taking the absolute longest, most detailed scenic route possible before they finally answer a simple question. Or they might be tangential, wandering off on a tangent and literally never coming back to the point. Doctors listen closely for a flight of ideas, where the mind races from concept to concept, or loose associations, where the logical bridge between two sentences has completely collapsed.
At the extreme end of the spectrum, the examiner is listening for severe disruptions. Things like clang associations, where words are chosen simply because they rhyme, sounding almost like some kind of nonsensical poetry. Then there are neologisms. These are entirely made-up words that literally only exist inside the patient's mind. And finally, word salad, which is exactly what it sounds like, a severely disorganized, completely incomprehensible jumble of language.
To complete the whole picture, a rigorous cognitive test is administered to test, well, basically the hardware of the brain. The doctor checks alertness and orientation. Do they know the time, the place, who they are? They test both short and long-term memory. They even assess abstract thinking. For example, they might ask a patient to interpret a really common proverb just to see if their mind is working literally or conceptually.
Ultimately, the entire examination culminates in two really critical factors: judgment and insight. Judgment explores what a patient would logically do in a hypothetical emergency. But insight? Insight is arguably the most profound metric of all. Does the patient truly understand that they are ill? Because without insight, getting them into voluntary treatment is incredibly difficult to achieve.
And here's the kicker. Because the human mind is so dynamic, a single snapshot just doesn't cut it. In fact, serial MSEs may be required. A patient's mental status can wildly shift from morning to night. So this means this entire intricate process of observation often needs to be repeated sequentially over time to accurately track the course of the illness. So by turning a highly subjective mystery into this incredibly methodical, deeply empathetic investigation, the psychiatrist essentially creates a map. And it's this exact map that helps guide the patient toward their own road to recovery. But it does leave us with a pretty fascinating question to ponder. As technology and AI continue to advance at lightning speed in medicine, will the deeply human art of the psychiatric interview remain the absolute gold standard? Or will machines eventually learn to decode the human mind even better than we can? Thanks so much for joining me on this explainer, and keep learning.